And first of all, I'd like to express my gratitude to Dr. Prakash, Anthony, and Anish for this wonderful invitation. It's always a great pleasure to be in Calcutta. Now, today I'm going to basically talk about biologicals in IBD. So the first image which comes to my mind is of this car, so this is, like there were times when you had to buy a car, you would say, okay, it was so easy to take a decision. You had to go, okay, Maruti, Maximum Zen. It would take you just 5 minutes to make the decision. All you needed to do was buy a car. Today, if you have to buy a car, you suddenly realize that it's a whole family meeting where like it is multiple meetings, many things which you consider. You want a SUV, you want a car which should have saleable value. There are so many options which are available. So what relevance does it have to the field of IBD? What we realize is that many years back, it was simpler to treat IBD that way. You had steroids, you had like azathioprine, that's all. And maybe like infliximab came up on the scene. And today, today we find that there are plenty of options which are available. And the problem with all these options are that yes, they may be effective, they may be good, but you need to be aware of the nuances which are associated with each option. Each option works, but when does it work? That is totally dependent upon you. So the patient's treatment depends upon whether you're able to take a smart decision or not. Let's see this case. 75-year-old gentleman, in 1975, he was diagnosed to have ulcerative colitis. Initially, he was being treated at PGI Chandigarh, where he was diagnosed as ulcerative colitis, treated with sulfasalazine and 5-ASA, and for 20-30 years, he did extremely well. He never had any major relapses. But maybe just because there were so many medicines coming up or whatever, in last 8 to 10 years, it was seen that the patient started having frequent relapses. He required many courses of steroids on and off, as azathioprine was not helping this gentleman. So he was advised that, okay, anti-TNF inhibitors are there. You can take infliximab, adalimumab. Why don't you try it out? But he was not very keen on it because somehow it had been impressed upon him that these agents are associated with infectious complications. So he just continued like this. Thereafter, by this time, July 2020, he had steroid-dependent disease, azathioprine non-responsive, anemia, hypoalbuminemia, fecal calprotectin, which is very high, and weight loss. So what would you do in such a setting? Obviously, in such a setting, first thing you would do is screen for malignancy, long-standing disease. Look for CMV, whether there's any evidence of CMV colitis. Optimize 5-ASA, build up his nutrition, give him some partial enteral nutrition and all. And he was again advised, okay. He was told that, okay, we have another monoclonal antibody available, which is a lymphocyte trafficking inhibitor known as vedolizumab. Why don't you try this out? So he was given vedolizumab. He was given 3 doses, and he responded. He did well. Clinical remission, UCI scores dropped down, fecal calprotectin score dropped down. But after 4 doses of vedolizumab, the patient had a relapse. So what to do? The options were, again now, do we send him back to anti-TNFs? He never had anti-TNFs. Do we again talk about that? Colectomy at the age of 75. By this time, oral small molecules in the form of tofacitinib had also come up. So he was advised that, okay, maybe you can try this out. The gentleman was started on tofacitinib, 10 milligram twice daily, and subsequently, it seemed to do good to him. He has gone into clinical remission and is doing well with a good hemoglobin and albumin. So essentially, this case is to highlight that today you have many options. And you should know, but how you are going to place which option above another, that is something a discerning IBD treating physician should very much know. Another case, 40-year-old lady who basically is staying in USA, in California. She developed ulcerative colitis 2 years duration, E2 disease, given 1 course of steroids and 5-ASA, but still had some amount of moderate activity. So the physician in US told her, you need to be put on infliximab or vedolizumab. She was visiting her parents in Delhi, so she came upon for an opinion and asked that which one should she start. Now, what will be your reaction out here? The reaction out here would be, aren't you missing a step? Are you not being too exuberant about starting biologics? The patient has not been started on azathioprine at all. The patient has been just given 1 course of steroids. And obviously, so this is the other extreme. That is, you do not jump the gun. It's not necessary that if you have a hammer, you have to hit the nail every time. Be very clear about it, when you're going to start and how you're going to start. So these are various algorithms I'm going to go through. So some of you may have seen some of these algorithms, but I have added another nuance to it, and that is I have added ustekinumab to it. The reason I have added ustekinumab to it is because ustekinumab may be launched in the market in near future. So I thought we should start talking about it. Ustekinumab is an IL-12, IL-23 monoclonal antibody. So the facets out here are that you have rich people, rich patients, you have poor patients. So obviously your choices also depend upon how much the patient can afford. So let's say a patient of acute severe ulcerative colitis not responding to IV steroids. These are all the options which are available in your closet. Which one are you going to use and which ones you're not going to use? So infliximab still fits the bill very well because it acts very fast. The largest body of data is available for that. As you all know, cyclosporin in this setting is equivalent to infliximab. Surgery is also a good option if the patient has not responded to IV steroids. Tofacitinib is something which has come up and is on case series data is available, whereby it has been shown to be very useful in patients with acute severe ulcerative colitis, except the dose for tofacitinib out here would be 10 milligram TDS for 3 days, and subsequently 10 milligram twice a day induction dosing for 2 months, and then you go down to 5 milligram twice a day. If there's a failure of infliximab, then again you can use tofacitinib. The agents which should not be used. In a certain anecdotal case, they may help, but majority of the cases, they would not help in such a setting. Acute severe ulcerative colitis is adalimumab, vedolizumab, ustekinumab. Vedolizumab because of its slow onset of action, adalimumab probably because it is not weight-based, it is subcutaneous, and ustekinumab again probably because of its slower onset of action. Now comes steroid-dependent ulcerative colitis, no response to azathioprine. Again, the two parameters remain regarding the socioeconomic status, and you have these choices. There's another drug which has come out here which can be used, that is budesonide preparations have also come up. We had budesonide controlled release preparation. That was effective more in the small intestine, was getting released somewhere in the distal ileum, and it would be more effective out there. So came up the MMX preparation of budesonide, the budesonide MMX. Budesonide MMX gets released in the colon. So if a patient of ulcerative colitis is doing well on 5-ASA, has a mild relapse, mild to moderate colitis, it is worthwhile to give budesonide MMX at that stage. Why? Because its first pass metabolism is high, the side effects are low, and for 8 weeks, if you give 9 milligram, the patient may get a response. Suppose the patient does not respond to budesonide, he does not respond to azathioprine, then these are the various choices which are available to you. What would you like to do out here? What you would find out here is that infliximab, or in some of the guidelines, even vedolizumab is being considered as a first-line therapy. But remember that infliximab still has the largest data for ulcerative colitis, and both infliximab and vedolizumab would be superior to adalimumab in this setting as the first-line therapy. If a patient is on infliximab not responding, then you can switch over. Otherwise, you would like to start with infliximab or vedolizumab. Surgery remains a very good choice in this setting. We tend to underuse surgery. The reason being, as in the morning, like I think Shiriji told you about the 3-step colectomy procedures and all, so it's a long drawn-out process. So the surgeon is afraid, the patient is afraid and you need to choose a surgeon. You need to have a good learning curve for pouch surgery if you want excellent results. But yes, for 80% of patients really do very well with surgery. So surgery is an excellent option, and comes up another good option for the poor people, particularly in the Indian setting where tofacitinib is. The cost is much less. The cost is somewhere around 4,500 rupees a month, as much a cost for 5-ASA. So there will be 2 thumbs up for tofacitinib out here, and this would be the dose. If the patient does not respond to any of these agents, then you can go in for ustekinumab or tofacitinib. That would be an excellent choice. Steroid-dependent ulcerative colitis patient, elderly, prone to infection, previous history of malignancy. What are you going to do in this setting? The patient has not responded to azathioprine. Remember that anti-TNFs we are always afraid to use when a patient has a very recent history of malignancy, because it can cause recurrence of malignancy. Same is the case scenario with azathioprine also. So the players are the same, but which player you would like to use out here? Here, vedolizumab or ustekinumab, they fit in the bill the best. Why? Because they are considered to be safe, very safe drugs. Vedolizumab has been considered to be very safe drug, and now data which is emerging shows that ustekinumab is also rivaling it in terms of safety. It also leads to very less chances of infection, and obviously if any of them fail, then you can switch over. Now, a patient of steroid-dependent ulcerative colitis, he comes with arthralgias, or he comes with ankylosing spondylitis, or comes with uveitis, pyoderma gangrenosum, autoimmune hepatitis. Extraintestinal manifestations are the predominant thing. So if extraintestinal manifestations are predominant, which drug do you think would be most useful if the patient is not responding to steroids, not responding to azathioprine? There you have to realize that vedolizumab will definitely not be useful. In fact, vedolizumab may promote a little bit of arthralgias. Surgery may not be useful at all because surgery is going to take care of the colon only. The drugs which will be useful would be infliximab, adalimumab, ustekinumab, yes, it has been shown to be effective in such a setting, and tofacitinib, yes. Tofacitinib again has been shown to be effective in a case with extraintestinal manifestations. IBD with pregnancy, no response to steroids. So again, which drug to use? The thing which you can clearly take out is tofacitinib because it has been shown to be teratogenic. And what you find is that infliximab, adalimumab, yes, excellent data available. Vedolizumab, ustekinumab, the data is emerging. They are considered to be safe, but not clearly 100%, but yes, good data is emerging. Surgery obviously would not be an option. Now let's come to Crohn's disease. So in a way, the flowcharts are something that if you keep them in mind, the patient comes, that helps you to decide, okay, these are the pluses and minuses for each of the agents. Steroid-dependent Crohn's disease, again, poor, rich, so these are the options which are there for the poor. What you find out here is that tofacitinib just crashes out. Tofacitinib has not been found to be effective in randomized controlled trials for Crohn's disease, so unfortunately, we cannot use that in patients with Crohn's disease, unless until for a given case you may want to use. The next JAK inhibitor which is coming up is upadacitinib, which is a JAK1 inhibitor. That has been shown to be useful in Crohn's disease. So that is something which once it comes to the country and it is not as expensive also, it may be useful. So for the rest of at present, these are our options out here. So what changes out here compared to ulcerative colitis? In ulcerative colitis, we had said infliximab has the largest data of experience, then would be vedolizumab, and adalimumab probably is inferior to these two drugs. In Crohn's disease, the change which comes out is that infliximab and adalimumab, they have roughly similar amount of efficacy data in this setting. So you can use either one of them. Adalimumab is subcutaneous, so it is easier to use for some patients. They can just take it at home and all. Vedolizumab is effective in Crohn's disease, but vedolizumab acts slowly. So if quantum of inflammation is very high, it will not have a very good action. If a patient has a stricturing disease, fistulizing disease, it will not have a very good action. However, if a patient has a luminal disease, inflammatory disease, there it will be effective. And if there is failure of first-line therapy, then obviously you just jiggle around. If you have used infliximab, you'll go to adalimumab or you'll go to vedolizumab. Now, B2, B3 Crohn's disease, that is stricturing disease or fistulizing disease, which I just talked about. Again, tofacitinib is out, and again here, inflixi or adali would be the two agents which may be used. Remember, in our country, surgery remains underutilized not only for ulcerative colitis, but also for Crohn's disease. Even though there may be a 90% chance of recurrence after surgery in Crohn's disease, yet at the same time, for 5 to 10 years, it takes away the disease burden. And if you start treatment for preventing post-operative recurrence, then the chances of recurrence or the progression of recurrence is also slow. So surgery is one very good option, both for ulcerative colitis and Crohn's disease, and somehow we tend to underutilize it. Now, let's talk a little bit from the patient's perspective, because as you know, like IBD is a chronic disease. It is something not where you make a decision, oh, I've started biologicals and that is enough, and you go home and the patient goes home. It doesn't end like that. So remember that there's a movie like Pat Adams where there's a very nice saying, you treat a disease, you win, you lose. You treat a person, I guarantee you, you'll win no matter what the outcome. And that's very true for chronic diseases like IBD. So the first 5 questions which I think a patient asks is, whenever you're starting a patient on biologics, is it the right time to start biologics? Can't we not delay it? Is the biosimilar, which is less expensive, going to be as effective as an innovator molecule? Anti-TNF leads to TB reactivation, how to avoid it? Are biologicals going to be lifelong? And these are questions which any educated patient would want to ask you, and you have to give the answers. So right time to start biologics? Well, it has been shown that there is a dichotomy out here. In Crohn's disease patients, it was seen that if anti-TNF are started within 2 years of diagnosis, it leads to lower healthcare utilization. In ulcerative colitis, however, the same effect was not seen. What about vedolizumab? Would vedolizumab also do the same? No. Would change? No. It seems that in vedolizumab also, patients with Crohn's disease who were started more than earlier in disease course, less than 2 years, it led to much better responses. At the same time, the same effect was not seen in patients with ulcerative colitis. So we add up the two and a meta-analysis came up. It showed that starting biologics early in the course of disease was beneficial perhaps to a patient with Crohn's disease, but the same benefit was not extended to a patient with ulcerative colitis. So what is the implication of this? The implication of this is that if you're going to start biologics, in a case of ulcerative colitis, see that you have gone stepped up. Like you have gone through the steps of steroids, azathioprine, budesonide, MMX and all, before you move on to biologics, unless until the patient is very sick or the patient has acute severe ulcerative colitis not responding to IV steroids. Don't be in a hurry to start biologics thinking you'll be able to change the course of the disease. Whereas in a case of Crohn's disease, you may be right if you feel that the patient deserves biologics and you start it early in the course of disease, or if you want to go in for a top-down therapy that is straight on biologics in a case of fistulizing disease or stricturing small bowel Crohn's disease or previous history of major resection and all. Is the biosimilar going to be as effective? This is a very genuine question which I've seen not only the patient, but some doctors also feel so. That the patient was put on biosimilar, it is not acting, so can I change over to the originator molecule? Let's say the patient is on infliximab biosimilar. Can I change over to Remicade? Perhaps it would be useful. Obviously, it is more costly, so you feel the quality would be better. Is that true? Well, it seems that is not true because we have data from our country which has looked at, this is a 4-center data. This is from Dr. Gaudas Chaudhary, Dr. Ghoshal, Dr. Ajit Sood and AIIMS, and which looked at what are the patients who were put on adalimumab biosimilar, were the efficacy rates good? Yes, they were around 60%, but that is going to be the efficacy rate for any biological. Similarly, this is the data for infliximab biosimilar compared to the Remicade, which is the originator molecule, which shows almost similar efficacy, suggesting that, yes, you can pass on the cost cutting in terms of low-cost drugs to the patient without compromising on the efficacy. If the patient is not responding to a biosimilar, it does not mean that the drug is bad. It simply means that the patient is not responding to an anti-TNF monoclonal antibody, and you need to change the drug. That is what you need to do. That is go to a different class of drug. Anti-TNF leads to TB reactivation, very true. It has been shown that around 10% cases of TB reactivation occur, particularly in a TB endemic country like India, when they are put on infliximab or they are put on adalimumab. Is there some way by which you can cut the risk? So how have we been doing earlier? Like we have been screening for latent TB? Okay, we have been doing it, but we have been lax in the way we do it. We say, okay, just do either a MON2 or you do a IGRA or do a chest X-ray, that's all. However, if you have a stringent screening strategy means do in TST, do IGRA, do a CT chest, not a chest X-ray, because a CT chest has higher chances of picking up old TB. Look for past history of TB. And if you find any one of them is positive, that is even the CT chest showing some evidence of old TB, this is extremely, extremely important, then you can give them INH prophylaxis. And what happens when you give them INH prophylaxis? So when we followed a cohort which were on anti-TNF, where we were screening them, but not the rigorous way which is recommended now, when we applied this strategy. And subsequently, we had patients who were screened very rigorously. The rates dramatically fell down. We had only 1 out of those 59 who developed tuberculosis, whereas earlier we always had 1 patient with TB reactivation lying in the ward. So the simple strategy whereby you check in all the boxes, do TST, do IGRA, do CT chest, look for past history of TB is a very simple strategy, just checking all the boxes, and clearly you can decrease the rate of TB reactivation. Is biological therapy going to be lifelong? This is obviously a very standard query in everybody's mind. So Why would you stop biologicals? If I ask any one of you out here, I don't think if a patient can afford and if a patient is doing well, anybody would start biologicals. Most of the time, people would not. If the patient is happy, if the disease is under control, patient can afford it, there are no side effects occurring, fine. But most of the times what happens is that cost is a major issue. Then somewhere down the line, the patient feels that they are on a very high-end medicine, it is going to lead to side effects and all, then they would like to stop. So they keep on asking persistently, when should we stop? Or before, while starting only, they want to know how many years or months they have to take it. So in general, if a patient is somewhere around 1 or 2 years after starting biologics in clinical as well as mucosal remission, clinical remission as well as endoscopic healing, or if it's a case of Crohn's disease, you have shown transmural healing, then you can stop the biologicals, but remember you have to continue azathioprine or methotrexate. Be prepared for a relapse. The relapse rates are around 40 to 50% at 1 and 2 years. But then 50%, the brighter side is 50% of them had a drug holiday for these 2 years. And even when they have a relapse, if you start the same biological, the biological seems to act. There are cases like where you would not like to stop biologicals. That is aggressive Crohn's disease, a case of perianal Crohn's disease, where you stop biologics, the chance of reactivation are very high. But again, as this cohort showed, that around 50% of patients, they have a relapse, and around 56% had a relapse. In other words, 40% did not have a relapse of 1 or 2 years. So even in cases with perianal fistulizing disease, you can take the chance of stopping biologics, provided the patient has had a complete response, and if you have demonstrated radiological healing on MRI, then you are very sure that this is the best candidate to maintain the response even when biologicals are stopped. And remember, continue azathioprine or methotrexate, do not stop them. Can a short course of biologics work? I have money for only 3 injections. Obviously now the patient requires biologics. He says, I have got 3 injections. Would you like to do that or not? What would do in such a kind of setting? So there's a very interesting study from Ludhiana, Dr. Ajit Sood's group, which showed that patients of ulcerative colitis, they were given only severe ulcerative colitis, they were given 3 doses of infliximab, and thereafter continued on azathioprine, followed up for 2 years, 5 years and all. And it was seen that 60% of them, they maintained a response at 2 years, 35% at 6 years. Again showing that for a proportion of people, particularly patients with ulcerative colitis, this strategy may work, where because initially the forest is on fire, you need to put in a lot of water, you're given infliximab, the fire goes down. Thereafter, once the fire goes down, you can maintain with azathioprine, and that can help in maintaining the response for a long time. But what if you give azathioprine for a long time? Aren't we all taught that azathioprine leads to lymphoma? So we should not give it for more than 4 years, for more than 7 years. Well, it seems that azathioprine is associated with lymphoma, but the risk may be a little overhyped. Particularly as we see in patients from India, this is data of around 1,000 patients, where 254 were on azathioprine for more than 5 years, around 68 patients were on azathioprine for more than 10 years. None of them developed a lymphoma, suggesting, yes, the risk is there. You cannot, with just sample size, you can't say there is no risk. But yes, at the same time, the risk is a little bit, is not that much, so you can safely continue with azathioprine, and that's what we have seen in patients of renal transplant our nephrology colleagues have been doing. Then now I put up, there's a recent scheme which came up, Agnipath scheme. Agnipath is where people go into services, only 25% of them are retained after 4 to 5 years. So again, you'll ask, what has this got to do with biologics? Well, if you start biologics, you will find that if you started 10 patients on biologicals, ultimately after 1 or 2 years, only 2 of them would be retaining on biologics, or at the end of 4 years. The reasons would be some of them may have a reactivation of TB, some other side effect. Primary non-response is 20 to 30% of cases. Every year, biologicals are proteins. They would be antibody formed. So every year, there would be 5 to 10% drop. So as a physician, you would like to know what are the predictors of success. How am I going to decide the biological is going to work or not? I'll take 2-3 minutes. So the general parameters have been that the patient look for pharmacokinetics, pharmacodynamics, and also look for whether there has been any initial response. And there has been another factor which has been touted to be, that is oncostatin M, which is, if it is very high, it has been found to be associated with a non-response to anti-TNF. Shirijit showed you this in his talk today morning about anti-TNF levels. I'll just cover it very briefly, that if a patient is not doing well, then only you would like to go in for therapeutic drug monitoring. Don't unnecessarily monitor drug levels. They are expensive and they are also not available easily. So if you find a patient is not doing well, look for objective evidence of inflammation and subsequently measure only the drug level. If the drug level is high, then you know that regardless of this drug is not working, you need to switch the class of therapy. That infliximab very high levels, go out, go to vedolizumab, or if tofacitinib is there, go for that. If the patient does not have inadequate drug levels, then only do a drug antibody levels. This will save your cost. If the drug level antibody levels are high, consider another anti-TNF. If the drug levels are low, as well as the antibody levels are low, go for dose escalation. So, what is the single most important factor, since drug levels again are not available for adalimumab? Drug levels are not available for vedolizumab. Drug levels for infliximab are also costly to do that, since they look at serum albumin. If serum albumin is low, then you know that in most of these cases, the biologicals are not going to work, and you would like to improve the serum albumin by giving them exclusive enteral nutrition or whatever way. If you build up their albumin levels, that would really help for the biologicals to act. Are Crohn's disease strictures responsive to drug therapy? People thought they may not be useful, but no. The stricturing Crohn's disease, even though it may have some amount of fibrosis, just because there is a lot of inflammatory element out there, so stricturing Crohn's disease patients, they are responsive to anti-TNF therapy. In fact, a recent study which came up, Strident study, which gave patients a lot of adalimumab, high-dose adalimumab, 160 milligram every week for 4 weeks as an induction dosing. And the other was a standard dose arm, and it was seen that in both the arms, the responses were very good. That is the heartening thing. Although there was no difference between both of them clinically, radiologically there was a difference, but clinically there was no difference, but the responses were in the range of 65-70%, showing that in stricturing Crohn's disease, again it helps, but there, choose the patient. If you have a patient of stricturing Crohn's disease like this, where there's a lot of fibrosis, you will be like driving a dead horse or something like that. Biologicals obviously are no role. Whereas if you have a patient out here, a lot of inflammation out here, CRP high, etc., biologicals are going to be pretty useful out here. Visualizing Crohn's disease, you have to treat infection, inflammation. Only biologicals are not going to act. You have to give antibiotics. You have to give ketone thread. And here, this is one issue area where top-down biologicals, straight away, if possible, you would like to start with biologics because they remain the first line of therapy. Steroids do not have any role in perianal visualizing Crohn's disease. So azathioprine, yes, has a role, but steroids do not have any role, right? Could you add one biological to another biological? You have a patient who is not responding. Is this strategy possible? Well, it seems that this strategy is possible, but again, the data is available in form of case reports, case series, no randomized controlled trials. What you see out here is that anti-TNF and tofacitinib is one combination you would not like to use in terms of adding. This is only for refractory cases. This is for very advanced cases. Whereas you can add anti-TNF to vedolizumab, anti-TNF to ustekinumab, or vedolizumab to tofacitinib, right? And finally, just one or two slides on other therapies are coming up. Ozanimod is an oral molecule, S1P modulator. Already last year, in NEJM, the induction and maintenance data has been shown. Subsequently, it has been shown in this year DW that tofacitinib is more effective than vedolizumab in ulcerative colitis with primary failure to more than one biological, helping you out in their decision process. And as I told you, in Crohn's disease, we do not have a molecule like tofacitinib, which is cheap and easy to use. So there, upadacitinib, if the data has come up that it is effective in Crohn's disease, once it comes up, it should be useful, clearly showing that the pendulum is swinging towards oral small molecules. Another 2 or 3 years, they are going to rule the roost. And finally, as I showed you, there are a lot of choices out there. The choices are, we have choices, another 5 choices I showed you, which are going to come to India another 2-3 years. Does it increase your happiness? I'm not very sure about it, because that is a paradox of choice. When you have more choices, your happiness quotient in a way goes down. In this case, why do I feel the happiness quotient goes down? Because I feel that what happened, you were changing one drug to another third drug to fourth drug. Some response for 6 months, then one response for 1 year, then one response. So I feel like IBD is like Ravana, in the sense that what you're doing with these drugs is you're just taking one head off, just taking a head. The head sprouts back. You gave anti-TNF for taking off one head. You have hurt the demon king, but obviously it has not decapitated him totally or something. You give subsequently vedolizumab, it acts, takes off one head. Then thereafter, the patient comes back with a relapse, you give tofacitinib, takes off another head. Relapse, you are going to give IL-12-23 inhibitor. Then IL-23 inhibitors are coming out. But that is not the issue. Till the time you have the real naval shot, the real kill shot, which would decimate the disease, till that time, remember, biologicals are just another tool. For youngsters, this is a message that generally we are very enthusiastic when we start biologics. We feel that it will change the course of the disease immediately. No. It is just another tool, and if you use it responsibly and properly, it would definitely help you, but it is not the final answer as yet. Thank you so much for your attention.